Next, we will have Dr. Saritha VK. She will be presenting role of YAG PA in angle closure disease.
Good afternoon, everyone. Thank you, Dr. Roshni, and the organizers of Drishti 2022 for giving me the opportunity to be part of this session. Straight to my topic, fire and rescue, role of YAG peripheral iridotomy in primary angle closure disease and management of acute angle closure attack. The first line treatment of primary angle closure disease is laser peripheral iridotomy because it is relatively non-invasive and has a favorable risk-benefit ratio. From the schematic diagram shown, it is clear that a patent peripheral iridotomy, it prevents a relative pupillary block. This is a UBM picture. In the second figure, you can see the patent peripheral iridotomy. The angle has widened and the iris has become flatter. Coming to the indications of laser peripheral iridotomy, the absolute indications are primary angle closure and primary angle closure glaucoma. And in case of acute angle closure, first of all, you have to reduce the intraocular pressure with systemic as well as topical medications. And once the cornea has become clear, you can do a laser PI. The prophylactic indications are you have to do laser PI in the fellow eye of acute angle closure if the angles are occludable, because there is a 50% chance of progression to acute angle closure within a 5-year period, as evident from the studies. Shall we do laser PI in all cases of primary angle closure suspect? No. Only in high-risk cases of primary angle closure suspect, we have to do laser PI. Like if there is a family history, or if the patient is a one-eyed, and if the patient requires frequent dilation for retinal evaluation, and if there is a history of rise in IOP after dilation, and in case of non-compliant patients and patients who cannot come for regular follow-up. And also you have to do laser PI in case of plateau iris configuration to counteract any element of relative pupillary block. Usually we use two types of lasers, ND-YAG as well as argon. We prefer ND-YAG just because it is faster, it has got a quick cutting action, it has a photo-disruptive effect. But the main disadvantage is that it may bleed, especially in case of patients on anticoagulants. And it is very difficult to do laser ND-YAG PI in case of a thick peripheral iris with no crypts. So in those cases, you have to supplement ND-YAG laser with or pre-treat the iris with argon laser, which has got a coagulative action, and the chance of bleeding is much less compared to YAG laser. Coming to the preparation, you have to get a written informed consent before the procedure. You can apply 2% pilocarpine to stretch the peripheral iris, and it has to be thin. Then you have to apply 3 times at an interval of 15 minutes and 1 hour before the procedure. You can apply topical brimonidine to prevent the post-procedural IOP spike. The patient has to be seated comfortably, anesthetize the cornea. You have to use a contact lens, and we usually use Abraham lens, which has got a plus 66 diopter plano convex button. What are the advantages? It acts as a speculum, it keeps the lids apart, and it minimizes corneal burns and focuses and increases power density on iris, and it also magnifies target site and tamponates bleeding. If there is bleeding, you have to press with the contact lens at least for 30 seconds. In most of the cases, the bleeding will be prevented. Coming to laser parameters, it is fixed for a particular machine, and the usual energy range is 48 millijoules, 1 to 3 pulses per application, and the spot size is 50 microns, 1 to 6 shots, and in most of the cases, a single sitting is needed. The slit lamp should be set at a high magnification, and you have to identify a crypt or a thinned out area in the superior peripheral part of the iris. Avoid the site where the lid bifurcates the cornea because it can produce serious or visual disturbances after the procedure. The aiming beam, which is a helium neon beam, it is brought to a focus single point onto the iris crypt and focus on the anterior iris stroma rather than on the surface of the iris to get the maximum photo-disruptive effect and also to avoid damage to the lens capsule. The end point is there will be a sudden gush of aqueous and pigment with a deepening of the anterior chamber. Ideal size is 150 to 250 micron, And you have to visualize a lens capsule, not rely on the red glow, because retroillumination may give false impression of patency. What will you do if you get a lamellar peripheral iridotomy? You have to repeat at the same or a different site after 1 week, once the inflammation has subsided. This is a short video showing the progression of the formation of a peripheral iridotomy with Nd:YAG laser. You can see the shots hitting and a beautiful peripheral iridotomy has been created. Coming to the post-laser management, you have to apply again alpha agonists like brimonidine to reduce the post-procedural IOP spike, measure intraocular pressure after 1 hour and 1 week because it is the time for the IOP spikes to occur, then topical steroids to counteract inflammation 4 times daily for a week, reassess AC depth gonioscopy, and check for the patency of the PI after 1 week, and dilate the pupil once the PI is patent to look for any posterior synecdoche, and also you have to evaluate the optic disc status. Coming to complications, these depends upon mainly on the total energy required, and one important is dysphotopsia. Patient may complain of linear dysphotopsia, but studies have suggested that it is irrespective of the site of the laser PI. Suppose if laser PI is not performed or if it is not possible, what will you do? You have to educate the patient about the symptoms of acute angle closure and to avoid medications causing pupillary dilation like sympathomimetics and parasympatholytics. Other options are surgical iridectomy, which has got its own complications. And again, you can rely on argon laser peripheral iridoplasty if it is available. Coming to my second topic, acute primary angle closure management. It is definitely an ophthalmic emergency. The pathophysiological mechanisms have been beautifully illustrated by Dr. Roshni. Coming to the treatment goals, the main treatment goals are to relieve the pupillary block. Second is to lower the intraocular pressure and associated pain, inflammation, nausea, vomiting, etc. The medical management, you have to take a brief history, check whether there is any cardiac or renal failure, and examine. You have to have an idea whether the angle closure is due to relative pupillary block or Plato iris or the retrolenticular causes. If the IOP is very high, you can start on systemic medications like oral carbonic anhydrase inhibitors, acetazolamide, 5 to 7 milligram per kilogram body weight. Then 20% mannitol also may be started. Then topical, simultaneously you can start on anti-glaucoma topical medications like beta blockers, timolol, again dorzolamide, and alpha agonists like brimonidine. What is the role of pilocarpine? It improves outflow once IOP is lowered enough to restore iris perfusion. You can start in the initial part itself, but it acts only if the iris has retained this perfusion. But it may produce paradoxical AC shallowing if the cause of angle closure is the lens. You can start on topical steroids to treat the inflammation, systemic analgesics, antiemetics, and if it is the pupillary block is not relieved and if the IOP is remaining high, you can even indent the central part of the cornea with a gonioscope or with even a bud. It may sometimes facilitate outflow. And anterior chamber paracentesis, it is controversial. It is up to the discretion of the treating surgeon. The laser peripheral iridotomy is the definitive treatment to relieve pupillary block. It should be performed as soon as possible. And don't forget to put a prophylactic PA in the contralateral eye. Other surgical interventions are surgical iridectomy, trabeculectomy, primary cataract extraction with or without goniosynechrolysis, which depends upon the amount of optic nerve damage and the associated visual field damage. Follow-up is 48 to 72 hours, 1, 6, and 12 weeks, and every 12 months. The take-home message is primary angle closure disease is largely undetected. It causes twice the proportion of bilateral blindness when compared to open angle. Do gonioscopy in all glaucoma patients. Do laser PI in indicated patients with primary angle closure disease. your timely intervention can prevent a person becoming blind. Thank you.
Thank you, ma'am.